Bismillah ar-Rahman ar-Rahim. Let's start with the Maudsley Prescribing Guidelines and other kind of general principles of prescribing in psychiatry. You're all mute at the moment, but if you have any question, you can unmute yourself at any time and and ask the question or give your comment at any time. You're most welcome. Let me and welcome Dr. Alam. So, so let's start with the sharing screen now. I won't be able to constantly share the actual guidelines due to the copyright issues, but what I will do is I will use the Microsoft Word template to write on my own. So uh, so let's share my screen here. And let's start with the prescribing guidelines from the very first page. Are you hearing all clearly? I hope so. So we start with the page one, and what they say is kind of that the chapter one is schizophrenia and related psychosis. So the chapter one is about the antipsychotics, and what they say is that there are conventional and atypical antipsychotics, but later they were like renamed uh, as kind of uh, first generation antipsychotics and second generation antipsychotics. So, and the reason for the renaming was that there was a lot of overlap. So we can't label one as typical and one as atypical. And starting with chlorpromazine, for example, chlorpromazine has a lot of anticholinergic side effects, and these anticholinergic side effects are helpful in reducing the extrapyramidal side effect load. So there are very few extrapyramidal side effects of chlorpromazine as compared to the other first generation antipsychotics. So that's about the chlorpromazine. And similarly, when we come to olanzapine, olanzapine also has an anticholinergic burden. Now we come to sulpride and amisulpride. So amisulpride, uh, you see, you cannot like amisulpride and sulpride are structurally very similar, but sulpride is classified in the as a conventional or typical antipsychotic, and amisulpride is atypical. So that's the discrepancy. So and that is why they stopped uh, calling it as typical and atypical. They said that it will be first generation and second generation. So amisulpride is kind of second generation. So there was a lot of overlap, and that was the reason. The first generation, which were developed first along the line, and the second generation, which came later, and a slightly different, you know, mechanism of producing side effects. Now, with the mechanism of action of antipsychotics, most of the researchers and are they agree that the basic mechanism of action of antipsychotic is D2 antagonism. That is the only kind of mechanism of action, and the other mechanisms of action are still not proven. They are being researched, but so far we have, I mean, apart from, I think there's something which was mentioned last week as well, which is a different antipsychotic mechanism of action. Otherwise, so far, all antipsychotics we have the same mechanism of action. And what is that? That mechanism of action is D2 antagonism. So, how D2 antagonism can be if we see brexpiprazole, aripiprazole, and cariprazine, we don't see that they are kind of D2 antagonists, but we tried to make it clear last time as well that there is a relative D2 antagonism, as Dr. Abdul Rahman said last week, that as compared to like a placebo, it is a D2 antagonism. So, or as compared to dopamine itself, it is a D2 antagonist. If you are giving dopamine, and what is happening in the mania and schizophrenia is that there is excess of dopamine in the brain. So when you are doing aripiprazole, you're producing a partial antagonism. It's not partial agonism only, it's a kind of partial antagonism as well, because anything partial is the partial, let's say if it is a 50% agonism, that at the same time it will be on a net, on a balance, it will be a 50% antagonism as well. And that's why it is like the British Psychopharmacology Association, they are agreed that this is the main mechanism of action of antipsychotic, which is partial or full D2 antagonism. And then they say that the side effects, for example, now, uh, so olanzapine can also produce extrapyramidal side effects. Even aripiprazole, we have seen full extrapyramidal side effects in some patients. And one of the EPSCs is so common with aripiprazole, which is akathisia. Any person on aripiprazole can develop akathisia. It's very, very common. And sometimes some clinicians give benzodiazepines for the first 2 or 3 weeks. And other strategies to avoid akathisia from aripiprazole is starting very low and increasing it very slow. And some patients may not tolerate it at all. So, the BAP, the British Association of Psychopharmacology, they say that if you are giving, for example, haloperidol, if you are giving very low doses of haloperidol, it will be the same effect as atypicals. So in low dose, it should not produce any extrapyramidal side effects. Except, if we go to the Asian population, they are a little bit more prone to the side effects of antipsychotics, the EPSCs. But overall, the 2 milligrams of haloperidol may not produce that much EPSCs. Similarly, 2 milligrams of risperidone may not produce that much EPSCs. So that's because you need at least 65% blockade to get some efficacy, and then you and something like that, it's 65 or 80, and then you after the 80%, maybe after 65% of blockade, you start having some effect, and after the and then there's something about 80% as well, that you can get full therapeutic effect at 80% blockage. So when you go above 80%, or above 65%, whatever it is the extrapyramidal side effects are seen. Now, clozapine is again, this is one of the antipsychotics which has very low uh, potential of causing EPSEs, and similarly quetiapine as well. So quetiapine is one of the reasons is like for clozapine and quetiapine is that especially clozapine, it binds the D3 and D4 receptors as well. And then please mute yourself if you can. So and then quetiapine has a very loose binding, and so clozapine. So what happens is that due to loose binding, it binds and unbinds, binds and unbinds, and whenever the movements are required, so because of the loose binding of like the dopamine receptors, the EPSCs do not happen, especially because of these two drugs, clozapine and quetiapine. So what they say here is of these medications, perhaps only clozapine and possibly quetiapine are completely atypical, because they will not give you the extrapyramidal side effects even at higher doses. I've seen only one patient who developed EPSCs on quetiapine, and I think he was like a chronic treatment resistant and the medication induced Parkinsonism, or which is kind of equivalent to Parkinson's disease. One more thing I wanted to say, that drug induced Parkinsonism, it is not always reversible. So in some patients, drug induced Parkinsonism can continue as it can continue uh, as a residual Parkinson's, or in the same way as a Parkinson's disease. And then if you're talking to a neurologist, a good neurologist will say that yes, it is drug induced, but they will realize that they have to treat it as a neurologist, because it will be equivalent to Parkinson's disease. It has kind of become, it's still like the residual symptoms are still going on, despite you have withdrawn the culprit antipsychotic. So here we are on this page. Okay, so the next, what we say is relative efficacy. So what they say is following the publication of independent KT and uh, Cutlass studies, the World Psychiatric Association reviewed the evidence related to FDAs and 11 SGAs, and one more side effect, which is called tardive dyskinesia, that is also produced by the antipsychotics. So choosing an antipsychotic, what an antipsychotic to choose here? Kindly unmute, sorry, kindly mute your mic, please. Okay. So, so this antipsychotic, choosing antipsychotic is always you have to see like whether the patient is like what and which antipsychotic to be given what drugs. So it depends on various factors. For example, if a person is very healthy young man and who is also kind of using drugs and in that case, you may use something like a typical antipsychotic. In elderly population, for example, you will go with conventional sorry, the second generation antipsychotics, and especially quetiapine in very elderly people, or very low dose haloperidol, very low dose risperidone, such as zero point 0.5 milligrams BD or OD, etc. So you have to consider pharmacology, pharmacokinetics. For example, like if you are saying whether to give something like so liver status is very, very important, and also the kidney status. So whether they are safe for the if their kidneys are uh, excreting the same amount or not. These all things are very important. So, and it could be very like tolerability can vary from patient to patient. Some people you find will gain a lot of weight from olanzapine. Some people won't. Similarly, about from clozapine, some people may not gain any weight from clozapine, and some people it will blow up. Similarly, akathisia. Some people will have marked anesthesia, akathisia on aripiprazole, and some people will not get any akathisia from this aripiprazole. And then what Maudsley prescribing guidelines say that you have to do some use some scales for the antipsychotic side effects. So one is Glasgow antipsychotic side effect scale, GASS. That is one scale we need to use from time to time. So it is GASS, Glasgow Antipsychotic Side Effect Scale. And in England and Scotland, it is routinely, like it originated in Scotland, and then also in England, where I worked, it was being routinely used even by the nursing staff. The community nurses were using these scales to measure the side effects. Similarly, for non-neurological side effects, there's a scale called ANSWERS, uh, antipsychotic non-neurological side effects rating scales. So I haven't used it, but I will definitely look it up. Now, the next thing they say is that the non-adherence to antipsychotic is very common. And here the guaranteed medication delivery associated with depot long injectable antipsychotic preparations is unequivocally advantageous. And uh, so, I mean, a lot of time the pharmaceutical representatives will come that, oh, we have a depot and you can use. So without, I have no conflict of interest, and I would use any of the depots. They have a point that depot definitely increases the compliance. So I personally and many other clinicians may also have a low, uh, very low threshold of using the depot antipsychotics. So that is one thing. So one thing, and the Maudsley also says the same, that depot antipsychotics can be used. Now, I don't want you to play in the hands of pharmaceuticals. So even the typical depots are as good as atypical depots. So it could be any depot injection, could be flupentixol, zuclopentixol, and they're very commonly used. Zuclopentixol is very commonly used in the UK because of the cost effectiveness. And then there are relatively costier ones, for example, risperidone depot, which is given every 2 weeks, and then paliperidone depot, which is given every 4 weeks. Similarly, haloperidol depot is available, and that is also given by default. It is every 4 weeks, but some people can get it every week, every 2 weeks, or every 3 weeks. So that's where they talk about the depot. Uh, so I mean, my advice would be that, if you are a consultant, I myself have a relatively low threshold for using depot, and if you are and depends on the culture where you are working and the compliance of the patient. If the patient is compliant, then there is no need. But if there are any queries about the compliance, then we can use the depot antipsychotics without hesitation. Now, most of the time, the practical difficulties is that the patient has to be willing. So now here is your chance of selling the depot to the patient, so so that they can agree. But in very few patients who are involuntarily admitted, you might have to give depot against their will. So there are exceptions. Most of the times, the depots are given voluntarily, and you just say to the patient that it will be easier for you to get the medication. You will forget about the medication for the next 3 weeks or next 4 weeks. You don't have to worry about taking the medication at all. There will be side effects, and the side effects may be only for first 3 or 4 days. There will be more marked, and then the side effects will go. With the depots, what we have to do is we have to kind of switch the position of the depot. Some of the depots are given through deltoid, and most of the depots are given into the gluteal muscles. So nearly all the depots can be given intragluteal, I think including aripiprazole and paliperidone. But the newer depots, they can also be given through deltoid, and sometimes the default position of injecting is intradeltoid for the modern antipsychotic long-acting injections. The new word used for the depot is called LAI, or long-acting antipsychotics injection. So long-acting injections. And previously, the word used was depot. Word was mainly used. Are you following me, or up till now any questions?
Yes, we are with you, sir.
Okay, so the depot word was used because the traditional or first generation antipsychotics, their molecules are dissolved in oil, uh, and so they are oil based, and then there is small molecular bases as well, like they use a large molecule, for example haloperidol decanoate or zuclopentixol decanoate, plus they are dissolved in oil. So both things can make them stay longer in the gluteal region. But the modern antipsychotic injections, they are usually not oil based to my knowledge. So, and I will come to the chat box as well. Uh, they have usually more molecular differences, and that's why their absorption through the muscles is very, very slow. So the chat box, please share your views on use of penfluridol weekly used antipsychotic. Penfluridol, I am first time hearing the name. If you have any, Dr. Pranchu, if you, I mean, if you have any views, you can share it here now. Okay, so yeah, or if I get anything later on, I will search into it, penfluridol, and I'll write down the name, and if I know anything, I will let you know. So penfluridol. Okay, so the next one. So what they say is general prescribing principles. The lowest possible dose of antipsychotic should be used. For each patient, the dose should be titrated to the lowest known to be effective dose. Oh, sorry, penfluridol is used orally. Okay, that's fine. Yeah. So yeah, if you know anything, you can tell us, or otherwise I will search into it, because the name is very, very new to me. Okay. uh, Now almost all the antipsychotics, or I would say 100% all the antipsychotics which can be given intramuscularly can also be given orally, but vice versa is not true. So orally, most of the antipsychotics can be given as like most of the oral antipsychotics can also be given as an injection. There are exceptions. For example, there is no depot for amisulpride. There's no depot for trifluperazine, to my knowledge. No depot for quetiapine. Similarly, olanzapine, there is a depot injection, but you have to monitor for the side effects uh, for for very long, like for 2 or 3 hours, and then after, when you monitor for the side effects, only then the patient can go home, because I think it can cause something like hypotension, etc., and there are other side effects, immediate side effects. So that's why its use is not very, very common, and we don't routinely give uh, the olanzapine depot. And our professor has also joined. Welcome, Professor Imtiaz Dogar. So very welcome to our session, sir.
Thank you, sir. Thank you. Please keep continue. I'll be
Right.
listening.
Right, sir. Thank you. So what they say is that the lowest possible dose should be used. For each patient, the dose should be titrated to the lowest known to be effective, uh, uh, and then the dose increase should then take place only after 1 or 2 weeks of assessment, during which the patient is clearly showing poor or no response. So by default, you give, for example, you have started, so increase the dose after 1 week. So, and after 1 week, and then what they say is start low and go slow. Uh, And then they say is that there is a gathering evidence that lack of response at 2 weeks is a potent predictor of a later poor outcome. So where to increase the dose and where not to increase the dose? Okay, let's say you have increased the dose after 1 week. What they say is that after 2 weeks, if there is some response, continue the antipsychotic and continue increasing the dose. If there is no response at all, then there are two options. One is that you can either stop it there and then and switch it to another drug and maybe give it another 1 or 2 weeks, maximum 4 weeks. If there is no response, then there is no point in continuing that drug. So if there is some response, then you start increasing the dose. Same with antidepressants. If there is a response, then you increase the dose. There should be some response, some mood change. For example, if there is with antidepressants, if you're giving it mood is 1 to 10, 1 out of 10, and you have started it. So after even a couple of weeks, you should have some response, like that mood can be go up to 2 or 3, or the sleep may be better, or maybe there is 1 hour in a day the patient feels better. So, or energy is increased, something you see within the first 2 weeks. So here we are talking about antipsychotics. So we will like have some response in 2 weeks. If there is no response, then maybe consider changing it to some other thing. Now, with regular dosing of long-acting injections, plasma levels rise for at least 6 to 12 weeks after initiation. And that's a very uh, kind of commonly asked question. Uh, that when do the steady state of the depot injection is achieved. So it says that 6 to 12 weeks after the initiation, uh, and then after that there is a steady state is achieved. So we might have to give some oral antipsychotics for for a few weeks at least, just to see that uh, so just to see the response, and like if there's and then we give oral at the same time, especially most of the cases, especially in the case of the uh, second generation antipsychotic depots. we usually give we usually give like the oral side by side, so that the response is seen, and then we uh, we start like we stop the oral and let the injection continue. So chat box, Hassan, can you unmute and explain what you want to ask, or if you can please write down again that what thing you want to be explained. You can rewrite in the chat box, or
So the thing that after initiation,
sorry, can you write in the chat box maybe? I'm not hearing you very clearly. Okay, so yeah, we'll when the question comes, yeah, after initiation of depot. So yeah, I think when we come to the depot injections, we will do that in more detail. But what happens is that first, for the first few weeks, you give some oral medication as well. For example, if you are giving aripiprazole, you can continue the oral for the next 3 to 6 weeks and then start tapering down the oral medications. So can we titrate the dose of risperidone from 4 to 6 milligrams if the patient is not showing any response? It may vary. I mean, if the patient is not showing any response at 4, any response, that means 0%, then it is unlikely that they will show any response to 6. So I may personally, may start to may consider changing it. But yes, you can try it, but don't waste your time too much. And if there is no response in even to 6 milligrams in another 1 to 2 weeks, just consider changing it to something else. Please mute yourself, please. Thank you.
Dr. Pranchu, Dr. Pranchu, please mute your mic. Thank you.
Okay. Okay. Sorry about that. So yeah. Okay. So I hope you're still seeing my screen and everything.
Yes, we are, sir.
Okay.
Continue, please.
Yeah. Okay. So so what we're saying is that long-acting injection. So if you're giving aripiprazole, so just keep giving some oral aripiprazole for another 3 to 6 weeks, and then taper it off later on, after the depot is established. So and the same with kind of paliperidone, you can wean it off early because you give first the loading dose of 150 milligrams. It is not like the other conventional antipsychotics. So you are giving the loading dose of 150 milligrams, and then you give the 100 milligrams after 1 week, and then you continue. Uh, I think Dr. Benazir, please mute anyone. Dr. Benazir.
Yes, sir. So you are the admin.
No. It's you now. So you can see who. You can mute them, please. Doctor. Yeah. Thank you. Okay. So so what I was saying is that like the so 6 to 12 weeks for every antipsychotic or only second generation. So I would say for every antipsychotics, 12 weeks is a very, very long time. For I mean, it may vary. What they say is that with regular dosing of long-acting injections, plasma levels rise for at least 6 to 12 weeks after initiation, even without a change in dose. See the section on depot pharmacokinetics. So it may vary from drug to drug, and then the dose increases during this time are therefore difficult to evaluate. So in some medications, it may take a long time. The preferred method is to establish efficacy and tolerability of oral medication at a particular dose, and then give the equivalent dose of that drug in long-acting injection form. Where this is not possible, the target dose of long-acting injections for an individual should be that established to be optimal in clear and clinical trials. So it varies from patient to patient. I was telling you about the paliperidone. So you, in the depot, always start with the test dose, which is kind of 50 or 100 milligrams of zuclopentixol, or 10 or 20 milligrams of flupentixol. But when we come to the uh, second generation antipsychotics, yeah, aripiprazole, there is no test dose. There's no test dose for the atypical antipsychotics. So we usually give uh, the total daily dose. And in risperidone, if you are giving the risperidone depot, Risperdal Consta, in that case, we build the oral for 3 to 6 weeks, then we give the depot. But for for aripiprazole, we can continue the oral for another 3 to 6 weeks.
Sir,
Yes.
how do we get to know that, for the particular drugs, there's is that we can shift to the oral medications, continue them for a specific period of time, and then starting with the and then waiting for the longer acting injectables to kick in. So how do we know that for which drug we can give orals and for which drug it's just that the depots are fine and we don't need to give him any oral drug?
Yeah, I mean, with aripiprazole, I generally continue the oral for 3 to 6 weeks. So for the maybe 1.5 depot duration. Depot is 1 monthly. So for the first month, I will give the full oral dose, and then for another 2 weeks after that. That is for the aripiprazole. For paliperidone, you can consider stopping it in 2 or 3 weeks because you're already giving the loading dose. So there is no kind of like no point of continuing the oral in addition to the injectable. So now they say that for the large majority of patients, a single antipsychotic with or without additional mood stabilizer or sedatives is recommended. Now, the next point is avoiding polypharmacy, and we see a lot of polypharmacy in our practice. So, ideally, there should be a single antipsychotic which should be prescribed. So, if it is olanzapine, do not give another antipsychotic, just continue on olanzapine. If it is risperidone, paliperidone, just give one drug, increase that drug with instead of adding another antipsychotic with both at low doses. So that's a very commonly occurring error that we do, is that we kind of give two drugs at subtherapeutic doses, but it is better to give one drug at a therapeutic dose. So, but there are exceptions to this rule. So, apart from exceptional circumstances, for example, clozapine augmentation, you have to, like, first of all, you have started clozapine, you're inducing clozapine in the patient for the first. So for cross taper, you might have to give two for sometimes because you are withdrawing one antipsychotic, you're giving another. So you have to cross taper and you have to give two for some time, for a number of weeks in case of cross tapering of any drug. Similarly, clozapine augmentation, you are giving clozapine at, you don't have to go to full 900 milligrams of clozapine before you consider augmentation. If you are giving 300 to 350 milligrams of clozapine, you can consider augmentation with, for example, with amisulpride, sulpride, or other aripiprazole, etc., even with haloperidol. So here that is a justified polypharmacy.
Sir, I have a question. If you could
Yes,
answer this in between.
please.
Sir, since we are cross-shaping one drug with the other, and there are chances of still NMS, since patient is on both the antipsychotic drugs, so how do we make the patient safe and how do we proceed?
I think we should be like, we have to balance the risk of relapse of the illness, or risk of worsening of illness with the other physical risks, metabolic risks, and kind of hemodynamic risks, the hypotension, etc. So if we do slow as possible, that is one thing. But if there is a more risk of relapse, or you want a very quicker response, then you might have to push up the new drug relatively quickly, not very quickly, but relatively quickly in those cases. Or if the patient is very tolerable, if the patient is manic, full of energy, and there are no chances of hypotension, then maybe you can increase olanzapine quickly if you're switching from risperidone to olanzapine. So you can give a relatively quick crossover. But otherwise, the crossover should take at least 2 to 3 weeks, or sometimes 4 weeks. If it is in outpatients, it can take several months. So it depends on patient tolerability and inpatient, outpatient settings, and also about the risk of relapse. Okay. So so that's the second kind of the circumstances where you can use something as a polypharmacy. The third justifiable polypharmacy, which I sometimes do, is when I give paliperidone or risperidone or uh, amisulpride or sulpiride. So it is sulpiride with a P-I, and amisulpride doesn't have an I, so it's amisulpride. That's how they are spelled. So with prides and peridones, I sometimes, if the prolactin levels are reasonably high, crossing more than 2000, then I might give a little bit of aripiprazole, 5 milligrams in addition to the normal dose of paliperidone or risperidone, whether it's oral or injectable, and same with amisulpride or sulpride. Another thing with polypharmacy, which I learned during my senior registrar training, is, and they are very particular. I mean, if you are using polypharmacy, then try avoiding the high dose prescribing. High dose prescribing is that you go for 100% of one drug, more than 100% of any one drug or the combination of two drugs. So if you are using, for example, risperidone is 8 milligrams. Now I'm using the like the example of quetiapine and risperidone combined, just for the sake of simplicity. So, so let's say risperidone, you are giving 2 milligrams. So that is about, let's say about, that's the 25%. Okay. If you have to give the 100%, that will be risperidone. 100% will be risperidone 8 milligrams, and that will be 100%. So quetiapine example is easier to use because you straight away multiply by 100, because it's a low potency drug. Risperidone is a high potency drug. So let's do with the quetiapine here. So quetiapine will be quetiapine. So 200 milligrams will be 25%. And now what we will do is quetiapine, and I will again copy and paste here. So quetiapine 800 milligrams will be 100%. Okay, so when you are combining risperidone and quetiapine, you should know that the combination should not exceed 100% of any one drug. So if you are giving risperidone 2 milligrams, you can combine, let's put it here, and quetiapine 8. So we can combine, let's say 600 milligrams and then 206 milligrams. So that's what we can do, is that you can give 25% the of the risperidone and 75% of quetiapine, and vice versa. So the combination should not exceed 100%. Now, what if it exceeds? If it exceeds, then we will call it a high dose prescribing. So when it goes to high dose prescribing, if you are working in the UK, you have to sign a high dose prescribing form. So do not go with high doses unless there is need, and do not go with combinations unless there is a justifiable need. So what they say is that for the large majority of the patients, the use of a single antipsychotic with or without additional mood stabilizers or sedatives is uh, uh, like or mood stabilizer sedatives is recommended. And apart from exceptional circumstances, for example, clozapine augmentation or antipsychotic polypharmacy should generally be avoidable because of the increased risk of adverse effect burden. So if you're giving two antipsychotics, they may pharmacokinetically interact with each other and pharmacodynamically as well, and they can give more side effect burden. And that's why they say that it's better to give only one antipsychotic at one time, not two. And then the risks of associated with QTC prolongation, sudden cardiac death, these are also, they're more pronounced uh, because uh, because if you're giving, they're more pronounced. The QTC prolongation risk is also increased. So combination of antipsychotics should only be used where response to a single antipsychotic, including clozapine, has been clearly demonstrated to be inadequate. In such cases, the effect of combination against the target symptoms and adverse effects should be carefully evaluated and documented. And whereas there is no benefit, treatment should revert to single antipsychotic therapy. And in general, antipsychotics should not be used as when necessary sedatives. Now, when I was trainee years ago, at that time we were not very strict about these things. So we could use, for example, like the antipsychotics as PRN or SOS basis. But now the Maudsley prescribing guidelines say that do not use antipsychotics on a PRN or an SOS basis. So if you are using anything as an SOS or PRN basis, then it is better to use either promethazine or sometimes benzodiazepines, or sometimes as a rapid tranquilization you can use exceptionally like haloperidol or olanzapine, but this is not for ordinary agitation. It's only for rapid tranquilization in very like when the patient is very agitated. In that case, you can use it as an SOS or PRN basis for rapid tranquilization only, but not in routines. So we should avoid the practice of giving olanzapine as an SOS basis. Even in delirium, the modern delirium guidelines and all the clinicians now give regular olanzapine, not LPR and not SOS anymore. Uh, so, I mean, you may find that your medical colleagues or colleagues in anesthesia or ICU may give some PR and haloperidol, but it's their choice. We as clinicians give generally regular uh, antipsychotics even in delirium. and usually it is olanzapine most of the time. However, it could be risperidone, quetiapine, or sometimes haloperidol. So it should not be used as when necessary sedative. Time-limited prescriptions of benzodiazepine or general sedatives such as promethazine are recommended. And then they say that see the section of rapid tranquilization in this chapter. Now, responses to antipsychotic drug treatment should be assessed using recognized rating scales and outcomes documented in patients' records. So response to antipsychotic drugs, and I will come to chat box after this comment. So, for example, how you will measure that the antipsychotic is it's working or not. If it is mania, you will go with the Young Mania Rating Scale, or if it is schizophrenia, you will go with the PANS, Positive and Negative Syndromal Scale, or and if you can't measure, at least you can have your own clinical judgment that it is, and ask the nursing staff. They are better than any rating scales. Trust your nurses, the nurses working in your ward. Ask how the patient is doing during the 24 hours, and they are the best judges of the patient. They will tell you whether the patient is improving or not. So trust their opinion 99% of the times. Then chat, dose of olanzapine in delirium, good question. Yeah, generally we start with 2.5 milligrams Nocte or HS. So uh, especially in the elderly, and we try not to increase more than 2.5% in elderly, but and then we gradually increase it very carefully if required. In general adult population, we may start with 2.5 or 5 milligrams OD, and then gradually increase it. In general adult population, we have used up to 20 milligrams per day of olanzapine. In elderly, that 20 milligram level is rarely achieved, seldom achieved. So we generally don't go above 10 milligrams in elderly, but sometimes in very exceptional cases, if the person is pulling out their NG tube or their airway or things like that, in that case we can go, but you have to liaise with the cardiologist or anesthetist or the medical colleagues who are treating the patient before going more than 10 milligrams in elderly population. Responses to antipsychotic treatments should be assessed using recognized rating scale and outcome documented in patients' records. Those receiving antipsychotics should undergo close monitoring of physical health. So physical health should be monitored, especially the blood pressure. Now, initially in the short term, antipsychotics will give rise to hypotension, but in long term, they will cause hypertension. So when you're starting, or even when you are recommencing or restarting in a patient who was non-compliant to antipsychotic for a long time, start with a low dose, even with the recommencing, and don't increase the dose very suddenly if they are recommencing after a long time, such as a few months. If it is only 1 week, you can go up quickly. But if it is a long time, because they will develop hypotension, and especially if they are on other antihypertensives, consider the drug interaction. The patient may go into hypotensive shock. So, is drug of choice in delirium is haloperidol? Yes, according to the Maudsley Prescribing Guidelines and according to the most of the guidelines, the drug of choice is still haloperidol. But I am very hopeful that in the next or the next to next uh, edition of Maudsley Prescribing Guidelines, the drug of choice will become olanzapine, because uh, the clinicians are now quite reluctant, despite that the fact that haloperidol is the drug of choice on the basis of anecdotal evidence, the most of the clinicians have started using olanzapine as the first line, including myself and including most of my colleagues working in England, especially in the liaison psychiatry. So it will become olanzapine in future. But yeah, the according to the guidelines, it is haloperidol, but start with very, very low doses, 0.5 milligrams to begin with. If you can, don't go with high doses. That's my, advice. Those receiving antipsychotics should undergo close monitoring of physical health, including BP, pulse ECG, plasma glucose, and plasma lipids. And then we'll come to these sections later on. If anybody has their mic unmuted, kindly mute it. Dr. Benazir, yeah, thank you. Okay. So, and now when withdrawing antipsychotics, reduce the dose slowly in a hyperbolic regime, which minimizes the risk of withdrawal symptoms and rebound psychosis. And so what they mean is that go very, very slow when you are withdrawing antipsychotics. It can take several months sometimes to withdrawing antipsychotics, especially in the
Sir,
outpatients. Otherwise, you are just giving a relapse. Yeah,
could you
question.
comment on this hyperbolic regime? What it actually means?
Okay, I will study it and maybe in the later sessions we'll come to it. I did read it, but it's out of my mind at the moment. So I will bring some pictures, and it is like hyperbolic is like a bowl. So the bowl could be like it could be a straight bowl in which we can eat cereals, or it could be an inverted bowl, ulta pyala it can be. But we'll come to the diagrams in the later sessions, inshallah. And then so for today I will go with only like one more page, and that is the page of equivalence of antipsychotics. So what they say is that table minimum dose, minimum effective doses, and then the equivalence at the same time, equivalence of the minimum effective dose, because it's not only minimum effective dose table, it also gives you some equivalence as well. So chlorpromazine 200 milligrams is the minimum effective. So when you start, of course, you will start with 50 or 100. Then 1 week you will give 200, and then you see whether it's working or not. But similarly, in multi-episodic schizophrenia or multi-episodic condition, especially schizophrenia we are talking about. So 300 milligrams will be the minimum effective dose, and that's what I tell my patients always, that if you're starting like if you stop your medication, the next time you, first of all, there are very smart chances that you will become unwell in the next 2 to 3 months. And when you become unwell, you will need higher doses. And that is one of the major causes of treatment resistance. Biggest cause, I would say, is that patients start uh, uh, so can you please, yeah, thank you. So yeah, so the patients, what they do is they stop the medication, and when they come back they need higher doses, and then more they are non-compliant, more are the chances that they might have to revert to clozapine in the end, or the depot. And that's why I have a low threshold of using the depots to prevent that treatment resistance, because in the multi-episode you will use more and more of the kind of like the doses of antipsychotics. Now haloperidol 2 milligrams And I remember, like our professor, when I was working in Pakistan in 2001 and 2002, like these studies, the BAP came to this, established this fact. The first studies were published in 2000, I think. And but the fact was established around 2010 or even after that, that these low doses are also equally effective. But our professor then in Pakistan, Professor Saad Malik, he was using, like he even used 1.5 milligrams of haloperidol, and one of the patients who was a milder case uh, got well on 1.5 milligram. That was an exception though. Most of the times we're using up to 5 or maximum 7.5 milligrams. We seldom have had to go more than 7.5 milligrams. And that's what it says here. 2 milligrams is effective. Multi-episode, maybe 4 milligrams is effective. And rather than giving anticholinergics, it's better to give only 2 milligrams or 4 milligrams. Otherwise, you have to go give 5 milligrams BD plus anticholinergics, procyclidine. So it's better to give low dose, and maybe using, if you are sure that you can withdraw benzodiazepines later on, then give some benzodiazepines in the beginning in inpatient settings, and then withdraw and stop them before discharging patient. And some clinicians may differ and may give 5 milligrams BD instead of giving benzos. That is fine, but don't go, more than 10 milligrams unless there is a dire need. Sulpride 400 milligrams can be effective, 800 milligrams multi-episodic. And I think the maximum dose could be 1200 milligrams or so. I'm not sure. It's sulpride, not amisulpride, so there are differences. Trifluperazine 10 milligrams is the minimum effective, and then 15 milligram. Amisulpride 300 and 400 milligrams can be minimum effective. So sulpride, you need higher doses to be effective. So amisulpride, yeah, it's the less. And you can see amisulpride, there's no PIR, it's only PRI, pride, while sulpiride, that's the difference. Aripiprazole 10 milligrams, asanapine 10, and then bionanserin, which we haven't used ever. Brexpiprazole 2, cariprazine 1.5, iloperidone 4, lumatripyrone, lurasidone, olanzapine 5 milligrams can be effective. So most of the times we only give 5 milligrams, and it works in some schizophrenics. And paliperidone 3 milligrams, and pimavanserin, it has a different mechanism of action as compared to other antipsychotics. So it is, if we see really atypical, that's pimavanserin, but I don't have much knowledge of that at the moment. I think Dr. Abdul Rahman mentioned its unique mechanism of action. Quetiapine 150 milligrams, risperidone 2 milligrams, ziprasidone 40 milligrams. Ziprasidone we seldom use now. It is still available, but we don't routinely use because of the side effect of QTC prolongation. Chat box. So do you believe that Asian population needs higher doses? So let's switch my screen. Yeah. So do you believe that Asian population needs higher doses than European countries? No, I believe in mania, maybe yes. In mania, they may need, because when I work in Pakistan, I see more severe manic episodes in Pakistani population. But here in Europe, we see relatively less severe. So in general, so yeah, with mania, we may need higher dose antipsychotics, but in schizophrenia, I would say use even less than European countries, because my experience is that, and I've worked in London as well, where there were Sri Lankans, Bengali, Pakistani, Indian patients and African. So from our subcontinent, Sri Lanka, India, Pakistan, Bangladesh, this subcontinent, people can develop akathisia and other side effects on very, very low doses. So I would keep doses rather low in Asian populations for psychosis. For mania, that's different, but even in like keep that in mind that you might have to use anticholinergics alongside in manic episode. Now the next question is
Since Dr. Imtiaz Ahmed Dogar is also with us, so I think he would give his input on this question. Since he works purely with the Asian population, I think that would be
yes,
helpful.
please, sir.
Dr.
Ji, thank
Imtiaz,
you.
are you with us?
Ji, I want to appreciate Dr. Kamran, mashallah. He's contributing a lot towards education of our youth and particularly all the residents. And thank God this time more people, they are listening directly. And talking
Yes.
about some of the aspects, if we try to summarize, of course, it's individual variation and your experience. Like talking about depots, Pakistan has only got conventional depots only. Even we don't have haloperidol, we've got only fluphenazine and then this clopidogrel and fluphenazine. Only three are available. And sometimes in our experience, we use these depots as even sometimes add-on if the effect is not coming. Talking about polypharmacy, yes, one shall be going according to book picture, and one shall be going with single drug and slowly increasing. But then seeing your experience and previous dosage, patient may be taking at outpatient. Well, in indoor, you can go for higher doses. What I believe, what I have seen. Of course, at the start, but if we see practically talking about antipsychotics like this, the best is yet to come. There is no ideal antipsychotic. If you're going to prescribe this, you have to monitor it in any way for side effects. And if we talk about like having a balance of typical and atypical, in Pakistan, we usually still use, in many of our cases, typical alcohol. Although the guidelines, they don't recommend, they say to discuss with your patients. And even if we talk to our patients, they give us full authority most of the time. They use whatever is appropriate. So in fact, the guidelines will justify. So I personally have got some reservations with olanzapine, although it's one of the recommended drugs. और फर्स्ट लाइन में हमारे रेजिडेंट्स भी ट्रेनिंग्स भी बाकी सारे भी यूज होती है लेकिन सीइंग इट्स वेट गेन पोटेंशियल एंड अदर मेटाबॉलिक साइड इफेक्ट्स मेरी थोड़ी सी रेजर्वेशन ही रहती हैं और एज ए एड ऑन समटाइम लो डोज में मैं यूज करता हूँ रिगार्डिंग कोटापिन अगेन हायर रिस्पॉन्स चाहिए होता है और अमंग द टिपिकल्स अगर आपका पेशेंट अग्रेसिव नहीं है तो यूजुअली मेरी चॉइस होती है साइकोसिस में टाइफ्लूपैराज़ीन and it's a wonderful drug having very less side effects और अगर कोई एंटीकोलिनर्जिक आ भी जाए तो प्रोसाइक्लिडिन से कवर हो जाते हैं और still there is a long way to go regarding use of antipsychotics और हमारे यहाँ जैसे हमारे रेजिडेंट्स हैं ये पढ़ भी रहे थे अटेंड भी कर रहे थे they shall be knowing availability of drugs sometimes वो बुक से पढ़ के जो डेपो उनको बेस्ट लगता है रिकमेंडेड वो बता देते हैं वहाँ और वो पाकिस्तान में अवेलेबल नहीं होता तो उसका इनफैक्ट नेगेटिव क्रेडिट होता है कि आप जो अपनी अवेलेबल चीज़ें हैं उनसे फेमिलियर हों जो आपके पास अवेलेबल है उनके यूज़ के लिहाज से बाकी चीज़ों लेकिन थ्योरेटिकली तो आपको बाकी सारी भी कामरान ने बताई कि whosoever is available वर्ल्ड ओवर और सबका पता होना चाहिए लेकिन प्रैक्टिकल एस्पेक्ट्स में जो आपके यूनिट में रूटीन में चीज़ें यूज़ हो रही हैं उनका तो डेफिनेटली आपको पता होना चाहिए जिनके साथ आप वेल तो ओवरऑल लोगों की पार्टिसिपेशन भी माशाल्लाह बड़ी अच्छी है और मैं तो इसको अप्रिशिएट करना चाहता हूँ एंड आई वांट के कीप इट अप कोई स्पेसिफिक क्वेश्चन है डॉक्टर बेन जी तो आप डायरेक्टली पूछ सकते हैं मैं भी डॉक्टर
one of the students have asked Pakistani population do they require more than the usual doses as prescribed in the guidelines do you think that they need a higher dose
regarding mania as Dr. Kamran has said you may use but again अगर आपका इन पास इन पेशेंट है तो आप स्लोली ही चलें आप लो डोज दें देखें इनफैक्ट नेक्स्ट डे आपका राउंड है नेक्स्ट डे राउंड है और आप देख रहे हैं आपके रेजिडेंट्स देख रहे हैं अगर वो अच्छा इफेक्ट नहीं आ रहा और आप मॉनिटरिंग कर सकते हैं, तो आपका एक्सपीरियंस बंदा हायर डोज भी दे सकता है, मैंने तो देखा है। और पॉलीफार्मेसी में अगर हम देखें तो यूरोप और अमेरिका का ट्रेंड डिफरेंट है। अगर हम अमेरिकन प्रेस्क्रिप्शंस देखते हैं तो ऑलवेज पॉलीफार्मेसी एंड हायर डोजेज दे आर देयर, एंड रेस्ट ऑफ द यूरोप सिंगल ड्रग है, मोनोथेरेपी है और लोअर डोज है, तो वेरिएबल है। तो पाकिस्तानी जो है वो दोनों को फॉलो करते हैं, जो जहाँ का ट्रेंड है, जो उसको जिसको सूट करे, या अपना विजडम अपना एक्सपीरियंस भी बीच में शामिल कर लेते हैं। लेकिन ऑफ कोर्स पेशेंट सेफ्टी, उसकी टॉलरेबिलिटी, ये दो ज्यादा अहम चीजें हैं। किसी जमाने में एफिकेसी होती थी, लेकिन अब इन चीजों को ज्यादा वैल्यू दी जाती है, लेकिन हमारे पेशेंट्स कर लेते हैं अमूमन, अगर आप देखें टॉलरेट। लेकिन सबसे अहम चीज वाइल प्रेस्क्राइबिंग एंटीसाइकोटिक्स इज monitoring of side effects, and you shall be very quick while sitting in OPD कि आप 3-4 मिनट्स में सारी हिस्ट्री, रेलेवेंट एग्जामिनेशन और इन्वेस्टिगेशन, और ये वन ऑफ द ऑस्पीस होता है ऑलवेज ऑलवेज, IMA में भी, पार्ट 2 में भी, और वैसे भी आना चाहिए रेजिडेंट कि कैसे आप मॉनिटरिंग करते हैं, फॉलो अप में कैसे एंटीसाइकोटिक्स को हैंडल करते हैं। बट द बेस्ट लाइक एंटी डिप्रेसेंट्स के आप एक दे के भूल जाएं और पेशेंट्स ठीक हैं और कोई साइड इफेक्ट नहीं है, इज येट टू कम। हम वहां लैग कर रहे हैं एंटीसाइकोटिक्स में।
Thank you, sir. Thank you very
Right,
much.
sir. Thank you.
And I just second the thoughts of Professor Imtiaz Dogar, especially in relation to the first generation antipsychotics. They are equally effective as the second generation. There is no difference in efficacy, and even in terms of negative symptoms, they are equally effective, especially if we go with amisulpride or sulpride. I mean, sulpride is a conventional, and amisulpride is an atypical, but these are, it is good for negative symptoms. And similarly, stelazine is conventionally, or trifluperazine, conventionally it is regarded effective for negative symptoms. So the traditional antipsychotics, do not lose faith in them. They are still in the market and they will stay as a first generation. That's why we don't say typical, we say first generation. They're equally effective and sometimes better to use the first generation than second generation, especially with terms of in terms of metabolic side effects. And as Professor was saying, with regards to depots, so yeah, when we come, we will especially focus with the when it comes to the long-acting injections chapter, we'll focus how to start with the haloperidol. I don't know if haloperidol depot is available in Pakistan or not, sir. Do you know?
No,
No,
it's not
sir.
It's not.
Alpidol.
No.
Yeah, and there used to be Modicate or flufenazine. I don't know if that's available or not.
Yes,
But
मॉडिकेट के अल्टरनेट्स
yeah,
Okay.
अवेलेबल हैं,
it is available.
मॉडिकेट्स के अवेलेबल हैं अल्टरनेट हमारे पास, वो हम
Yeah,
यूज भी करते हैं
yeah.
जी।
So we can discuss about flupentixol, zuclopentixol, and flufenazine, and how to initiate. We'll have more focus on starting those, and as sir said, that you should have the knowledge of others as well, but practically more knowledge and more competence in the things which are available in your country. Now, the next question is that I've seen a patient who was pregnant during my training who presented with neuroleptic malignant syndrome, and she was prescribed 80 milligrams of haloperidol by a senior consultant. So traditionally, yes, there used to be old school of thought, these doses had been used, no more, and patient may develop neuroleptic malignant syndrome. So try to even try to get below 10 if you can, or the maximum will be 20 milligrams. So you should not exceed 20 milligrams, especially if the pregnant patient. So these things are not common, or not even uncommon. They're not done in an anymore. If it is being done, that's against guidelines. So that's what I would
मैं
say.
आपको बताऊं डॉक्टर कामरान, इफ आई ऐड, 80 मिलीग्राम मुझे एग्जैजरेशन लगती है।
Yes.
मेरा नहीं ख्याल कोई भी किसी कंसल्टेंट ने ऐसे यूज किया होगा।
Yes, I agree.
Pakistan, everyone is prescribing, including quacks and everybody.
Yes.
Usually people can go up to 30, I've seen with their experience. And seeing in my practice, हम almost पूरे पाकिस्तान से prescriptions हमारे rotate करते हैं, एक दूसरे के पास आते जाते हैं। तो 80 नहीं होने लगा, और NMS आने के लिए डोज का कनेक्शन नहीं है।
Exactly.
So it come with lower dose.
Yeah, yeah. And yeah, that's right. And maybe in a very old school of thought, traditionally, if we go 50, 60 years ago, these doses may be followed at that time, but not anymore. So I fully agree with Professor. So I think we stop at that for today, and then we'll start with the next pages from next week. And
Right. Thank you so much, Dr. Imtiaz and Dr. Kamran, for joining us.
Thank you very much, Dr. Benzir, and thanks to Dr. Kamran for his special sparing time and educating us. Please keep it up.
Thank you, sir, for your encouragement, and it's all going under your supervision because you're like one of the senior most working professors in Pakistan at the moment. So it is very important that आपका दस्ते शफ़क़त हम पर कायम रहे. Thank you, sir.
Thank you. Pleasure.